This is Dr. Sargisian, and today we'll talk about neurologic system. When we're describing seizures, we have to realize that it's abnormal and sudden. At the same time, it's very excessive and also uncontrolled electrical discharge that occurs in the brain. And what's discharging, of course, is the neurons who release the charge. A seizure may result of alteration in consciousness, motor and sensory ability, or even behavior. And while we're saying this, of course, this can happen all together, all this alteration. So differentiation between seizures and epilepsy. Epilepsy is a chronic disorder when the recurrence is presence. With epilepsy, it's important to know that it's an unprovoked seizure. Basically, by unprovoked, we mean that everyone has some type of seizure threshold, and by seizure threshold, seizures are the result of resting potential instability. And again, when we're talking about this, we need to remember it's a burst of action potential. It's a significant discharge of energy, electrical energy. And the term for this is hypersynchronization. Seizure doesn't start in the entire brain at the same time. There is some epileptogenic focus, and by focus we mean there is a certain group of neurons that are sensitive to trigger, they are sensitive to depolarization, they are sensitive to some kind of external or internal agent or intervention that may cause the seizure. So tonic clonic seizures are generalized seizures, and again there is an area of hyperexcitable neurons, and that's again epileptogenic focus. So again, epileptogenic focus will be the source or the place where seizure starts taking place. So tonic phase is accompanied by laryngeal spasm. The autonomic reaction may occur at this time. Pulse and blood pressure may change, and the patient may have increased mucus secretion, and the tonic phase will approximately last like 15-20 seconds. And the clonic phase, it's the following phase when patient will have atonia and spasm, and the clonic phase will last 30 seconds approximately, or a little more or less. And at this time, alternation of atonia and spasm occurs. That's why it's clonic phase. Patient may become incontinent, may have urination, and may have even defecation at this time. So normally or usually the seizure, tonic clonic seizure, won't exceed 1 to 2 minutes, and postictal phase will follow the seizure. And at that time, when patient is questioned, or usually when patient is questioned, patient has amnesia of the seizure event. Patient may have confusion, lethargy, may have muscle pain, cramping, and psychosocial aspect of this important, because patients would have or may have embarrassment, considering that this may occur any place to any person who has history of seizures. So patient may have embarrassment, especially if this occurs in public, and even in hospital settings. Still, it's an unpleasant experience for the patient. Muscle pain, of course, comes from severe spasming of the muscles and will eventually resolve. So consequences of seizures are quite severe. Again, status epilepticus and death can occur. What happens, there is tremendous increase in adenosine triphosphate, the famous and your favorite ATP, you know, from citric acid cycle, and at the same time the cerebral oxygen consumption increase, blood flow increase, and what happens, the available resources of glucose and oxygen are depleted. So at that time, the severe seizure may produce hypoxia and acidosis and lactic acid or lactate accumulation. It may result in brain injury and destruction, and cellular exhaustion and destruction. That's the consequences of status epilepticus. And besides the injury to the brain, the injury to the body may occur in general from trauma. Patient also may be unconsciously biting the lips or tongue. Patient may have vertebral fracture of the long bones. Also, patient may have psychosocial consequences of the disease, such as strain on the relationship and alienation of the patient because of the seizure disorder, which nowadays probably doesn't occur that often, considering that most of the time seizure disorders can be controlled with medication. Epilepsy can be classified into 3 different types, and first of all, idiopathic. It's speculated that there is some neurogenic abnormalities or genetic abnormalities that affect this. However, the exact cause is not identified. So symptomatic, when we're talking about it, is epilepsy related to some type of lesion, and cryptogenic is the cause is unidentified, but at the same time we suspect that there is some type of lesion that causes it. However, by modern imaging techniques, we cannot identify that. Patients with idiopathic epilepsy may have some kind of family history, family members with of this type of epilepsy. Again, by family member we mean first-degree relatives, and in primary care or in healthcare, sometimes this term gets so much interpretation, family member, but family member is someone blood related and usually first-degree relative unless we are specifying otherwise. Epilepsy is characteristic with an aura, and aura is a sensation of that patient may experience that epilepsy is coming and may occur soon. So it's some type of warning at the same time. But some patients may not experience the aura, and the epilepsy, the seizure may start quite suddenly. So aura is some type of warning to the patient, and some patient will choose to take protective measures, especially if they are alone, to avoid the seizure, and it may be even medication versus just taking a safe position, such as acute confusional states occur secondary to external factors such as drug intoxication, some type of metabolic disorders, or neurosystem disease. You all probably at this point familiar patient presenting with confusion secondary to urinary tract infection. What happened, the disruption of reticular activating system of upper brainstem occurs, and patient may experience at this point acute confusion. What's important to know here that acute confusional state may have abrupt onset, and this is a differentiation from a disease that manifests itself over long period of time, such as dementia. Acute confusional state may happen to a patient who, or to a client who has no previous history of this, or haven't had any symptoms that may drive us to the conclusion that patient will fall into acute confusional state. So abrupt onset is one of the main characteristics of this, that there is really not much organic disease going on in here, but it's something that makes this a secondary consequence, such as a consequence again of urinary tract infection or a metabolic disturbance. On the other hand, when we're talking about dementia, dementia is a progressive failure, progressive disturbance of cerebral functions, and there is no impaired level of consciousness or altered mental status at this point may not be so significant in the beginning especially, but there is no impaired level of consciousness. Dementia is the state when your patient, where your patient lives. So to classify, brief classifications is a cortical, which examples are Alzheimer's and Pic disease, subcortical, Parkinson and Huntington disease, and cortical and subcortical mixed type, and infection and Creutzfeldt-Jakob diseases. To go more into the details, when we're talking about cortical disease, cortical dementia, Pic disease is an interesting example. People with Pic disease may have abnormal tangles or substances which are called Pic bodies or Pic cells inside the neurons in the areas of the brain that sustained damage. And Pic cell is a cell that contains abnormal protein called tau, and tau can be found in all types of cells, and all types of nerve cells, in all nerve cells, but unfortunately people with Pic disease has abnormal production of this protein. Pic disease is very rare, but it's much more devastating than Alzheimer because it affects younger group of population. It can start as early as 20, and but average age around mid-50s. Disease has progressively progressive character, and patient will experience symptoms that may be, or behaviors that may be typical for Alzheimer's disease as well, and patient will be having difficulty in social setting, and difficulty keeping job, inappropriate behaviors. But unlike Alzheimer's disease, Pic disease is resulting in personality changes, while Alzheimer is memory change. Again, Pic is personality change occur first, and Alzheimer is memory change. When we're talking about Alzheimer disease, Alzheimer type dementia, and Alzheimer disease can be divided into familial, early and late onset, and non-hereditary, sporadic or late onset. So in familial type of disease, there is a strong genetic component, while in non-hereditary, there is no evidence that anyone in family had the onset of the disease, but also the genetic component is still present. Alzheimer's disease is a combination disease of genetic, lifestyle, and environmental factors, unlike to popular belief that Alzheimer is only the reflection of genetic predisposition. The current school of thought is that Alzheimer is a combination of the above factors, such as environment, lifestyle, and genetic. So the chances of developing Alzheimer, even though the genetic predisposition is there, are relatively low. It's only 5% chance for a person to develop Alzheimer's disease with genetic predisposition. Patient also has to have a lifestyle history and also environmental factor or combination of the above. So what happened in Alzheimer's disease? The clumps of protein, beta amyloid protein, occur and they destroy the cells. They interfere with intracellular communication, and they will cause destruction of the cell to cell communication link. Also, the tangles will occur of the tau protein, and essentially this leads to death of the cells as well. The tangles of the tau proteins, we talk about the Pic disease, but still in Alzheimer they also present. The trademark of Alzheimer is the presence of beta amyloid proteins. Also, there are theories regarding alteration of apolipoprotein E and pathologic activation at MNDA, but again, the main theory is related to beta amyloid and tau proteins. Again, senile plugs and neurofibrillary tangles from tau proteins and plugs, beta amyloid plugs, can basically hinder the functioning of the brain, and clinically patient will develop forgetfulness. Again, in Alzheimer, the first symptoms is the memory changes, memory loss, and then personality change. And problem-solving abilities and judgment will decline, especially the classic example is balancing checkbook. When balancing checkbook is one of the activities the person was very used to do, although it's a complex activity, but it's been done many times. But if patient cannot balance the checkbook, it may be the onset of the Alzheimer. Of course, nowadays with development of online banking and other types of ways in dealing with money, using this universal balancing checkbook test, I would say, will not be appropriate because people more and more switching to other ways of dealing with money. Again, Alzheimer's disease is a diagnosis of exclusion, and diagnosis can be made by ruling out other causes of dementia. However, the real diagnosis can be made only by autopsy when the neurofibrillary tangles are present in the brain. Again, it's easy to describe or to label patient having an Alzheimer's disease based on their age. However, it can be number of different things, especially when the onset of mental confusion is rapid. Patient deserves and warrants a thorough evaluation of other causes, which can be metabolic or other neurologic diseases such as Parkinson. Another type of dementia is HIV-related dementia. Will affect anyone who has history of HIV, may be reflected in patients with HIV. Again, it's runs somewhat similar to Alzheimer because of its insidious course, but the problem is at the same time it's very unpredictable. While in Alzheimer's disease we know the stages of development and stages where it's going over the time, here the onset and development may become very rapid, and but eventually the end, the changes will be the same. Patient will present with cognitive system deficits and psychomotor slowing. Again, memory is one of the main signs, concentration, retrieval of the information, and it's very, very similar to Alzheimer in case of, in the sense of loss of balance, ataxia, and generalized, patient may have generalized hyperreflexia at the same time. Parkinson disease, it's a disease of degeneration of basal ganglia, corpus striatum, and involve the dopamine deficiency. Patient will have dopamine deficiency, and the treatment may be focused on several different agents that may replenish dopamine deficiency or make dopamine production or availability higher. Patient will present with rigidity, bradykinesia, tremor, postural abnormalities, shuffling gait, autonomic and neuroendocrine disorder. One of the autonomic disorders will be patient may have abnormal sweating and also cognitive affective symptoms. Patients with Parkinson also very prone to developing depression. Again, the treatment is treating the dopamine deficiency and trying to alleviate the symptoms. Parkinson may lead to development of dementia, and approximately half of the people who were diagnosed with Parkinson may have depression, and unfortunately that's the part of a pathologic state, and it's not a situational response. So it doesn't mean that patient develop depression and you give them antidepressant. They may not improve because some of your antidepressants may actually work on dopamine reuptake. So other patients may develop dementia, and patients with Parkinson disease who are institutionalized, means skilled nursing facilities, will have dementia quite often. unfortunately, the progression of disease leads to disorientation, confusion, memory changes, patient is distracted, has difficulty with concepts, judgment, thinking, and it reminds really that the dementia will be related to Parkinson disease, but at the end it may be very similar to Alzheimer. When patient with Parkinson develop dementia, there is again no steady progression to worse state, but eventually symptoms will worsen, but there may be better days or worse days. Patient also may have anxiety disorders, which also can be, or impulse control disorders, which also can be related to dopamine deficiency. Motor behavior is impaired, and also patients will develop stereotypic motor behavior when they may develop this fascination with repetitive handling and examining of mechanical objects. And one of the examples is the twisting the ring continuously and just holding it in the hands. Daytime sleepiness is one of the signs of this, and most people with, or more than 50% of people will develop that. Just a definition of disorders of gait, and it's spastic gait, scissor gait, cerebral gait, basal ganglion gait, and senile gait. Please review those in the textbook, and it's simple definitions. Disorders of the central and peripheral nervous system and neuromuscular junction. Cerebrovascular accidents can be divided into three main categories: thrombotic stroke, embolic, and hemorrhagic. Thrombotic stroke occurs within the brain, but it's as any stroke, but the thromb is formed within the brain, and it's formed in the arteries supplying the brain or in intracranial vessels. So TIAs are strokes that may be small thrombotic strokes, transient ischemic attacks. However, they resolve within 24 hours. Embolic stroke is very similar to thrombotic stroke, but embolic stroke is a consequence of traveling thrombus, which of course in this case will be called embolus, so it's embolic stroke. When the thromb is dislodged from other place in the body, such as in deep veins in lower extremities, and travels to the brain, this thrombus called an embolus. So the name of the stroke is embolic stroke. Again, thrombotic stroke, the clot formed inside the brain. Embolic stroke, clot comes from somewhere else. Hemorrhagic stroke is a stroke that caused by excessive bleeding in the brain and the damage to a blood vessel secondary to hypertension or any other factor that may disturb the flow. And this may, the main problem here is ischemia caused by excessive pressure, and as a consequence, the infarction may occur. Lacunar strokes are usually small strokes, and the lacuna is a small absent matter in the brain. At the same time, lacunar infarct are silent. So when on radiographic examination, it will be possible to see aneurysms are formation in the vessels in the brain that have tendency to rupture. And these are pictures of different aneurysm, and basically the aneurysm may be diagnosed by imaging study, and the treatment will be prevention of the rupture and stroke. At this time, one of the treatment may be placing a small clip on this and trying to isolate the aneurysm. The main thing is the patient diagnosed with it. It has to be treated, and the aneurysm has to be taken care of by placing a clip or by other means. Vascular malformations include cavernous angiomas, capillary telangiectasias, venous angiomas, and arteriovenous malformations, or AVMs. Vascular malformation at the same time are not very common occurrence, and they are not as common obviously as aneurysm. Cavernous angiomas are collections of blood vessels, but what about cavernous angiomas? There is no interference with normal brain tissue. Cavernous angioma rarely will result in hemorrhage, and so the treatment is rarely indicated. Telangiectasias is dilated capillaries. You can see telangiectasias on integumentary covering, on the skins, and telangiectasias in the brain may interfere or intercept with normal brain tissue, but again the hemorrhage is rare. Venous angioma can be presenting as a vascular malformation, and again rarely it can lead to drastic consequences, and rarely it can present with hemorrhage. And actually this is one of the most commonly found disorders or venous malformations, vascular malformation, when autopsy is performed. When we are looking at AVMs, this is a different story. And AVM, arteriovenous malformation, can occur in the brain or in other parts of the body, such as gastrointestinal tract, but most places they may hemorrhage quite often. So the arteriovascular malformation is arteries tangled into the vein, and it's malformed vessels. There is no capillary network. It's just it's a vein fed into the artery, or vice versa. So this formation may bleed, and they may rupture and cause a hemorrhagic stroke. AVMs on evaluations will be remarkable for systolic bruit, and when you auscultate the carotid arteries, and you may experience bruit. And also some sources recommend to auscultate eyeball, and also your textbook tells about it. However, this is rather unorthodox technique, but if you go extra mile and do it, you also can hear a bruit, and also this may be a sign of AVM. So treatment is surgical excision, embolization, and even radiotherapy. So the treatment may be very, very beneficial for the patient, but and can reduce the risk for hemorrhage. Subarachnoid hemorrhage is one of the conditions that need to be treated rather rapidly, and in this situation there is a rupture of the blood vessel, and blood is escaped in subarachnoid space, and it's becoming settle there and start to produce inflammatory response by irritating the tissues in the brain, such as meningeal and other types of tissues. So at this point, intracranial pressure will be increasing significantly, and because of the pumping action of the heart, at some point ICP will be coming up to diastolic levels, and which is relatively high, or very high, not relatively high, but eventually ICP will return to normal. Nevertheless, patients with subarachnoid hemorrhage may present with infarctions in the brain on radiographic examination. So patient will have altered mental status, nausea, vomiting, neurologic deficits, nuchal rigidity, and also patient may complain of the throbbing or explosive headache. And the patient will present with positive clonic sign and Brudzinski sign. And in these signs, of course, in kerning, straightening the knee with the hip will be producing pain in the back and neck, and Brudzinski is a passive flexion of the neck, will produce neck pain and rigidity. So treatment of subarachnoid hemorrhage is directed to prevention of cerebral ischemia, as well as it may include surgical treatment to correct the vessel dysfunction, and vessel dysfunction basically to correct vessel abnormality surgically. So risk factors for this is there is some genetic component, and familial history may be a risk factor. Headaches are one of the most commonly diagnosed condition, and there are these 4 types of headaches, and we need to know how to differentiate between them. Migraine headaches are presenting with trigger factors. There should be some type of trigger that will trigger them, and sometimes it's just stress or stressful situation. In migraine headaches is aura or warning, the same type of aura concept like we know in epilepsy is present. Migraine headaches usually unilateral, and they may be severe and may be sensitivity to noise, light, and patient may have nausea and vomiting. Cluster headache are most commonly occurring in male patients, while migraines are most commonly occurring in females. Cluster headache are happening usually unilaterally, and also may have a trigger that may induce them. However, cluster headaches will not have aura, and they may spontaneously resolve. So several attacks may occur in one day, and then patient may have periods of remission. Cluster headache can be triggered, and one of the most common triggers may be hunger in this case. But again, cluster headaches do not have aura, and they are more common in men. Chronic paroxysmal hemicrania is a type of cluster headache that will happen with higher frequency, but it will have shorter duration, and unlike a typical cluster headache, this may be experienced more often by women. And tension type headache, it's most common headache, and tension type headache is bilateral. If your patient tells you I'm having headache or I'm having migraine and my whole head hurts or my whole forehead hurts, this most likely not a migraine and it's a tension like a headache. And it will happen again more commonly in women, and again triggers may be present, and it may have even chronic characters. And while chronic characters of the headache can be diagnosed if it happens at least if it happens at least 15 days a month, or half of the time of the month, half month, and patient again can be diagnosed with chronic condition that it happened over the long duration of time. So you can say that over 3 months patient were having more than month and a half days with headaches, then it's a chronic headache. So these headaches can be treated by NSAIDs or over-the-counter other medication, and also prescription preparation. But why it's called attention headaches? Because there is a relation to contraction of muscles and jaw neck muscles, and exact mechanism is unknown, but there are some treatments with even Botox paralyzing the muscles and preventing the headaches, but they still have the experimental characters. Overall, there are many of the medications available, OTC and prescription, on the market to treat headaches, but again, this is one of the most common conditions diagnosed. So to recap, migraine headache, usually unilateral, has aura, sensitivity to light, nausea, vomiting. Cluster headache, unilateral, doesn't have aura. And tension type headache is bilateral, and it's usually related to some type of muscle tension. Cranial tumors. Meningitis is an acute inflammation of arachnoid and pia mater that surrounds the brain and spinal cord. So what happened in this case, this may lead to increased cerebrospinal fluid production and also some increase in intracranial pressure. So in this case, when we're having bacterial meningitis, meningococcal, it may be considered a medical emergency, and the mortality rate is relatively high of 25%. Viral meningitis, on the other hand, it's a fairly self-limiting condition, and that will not require a treatment at all. So meningitis can be caused by, again, bacteria, viruses, mycobacteria, fungal infection, even amoebas, cancer, or even non-infectious sources. The most common entryway is respiratory system. So in this case, when meningitis occurs, patient may have symptoms of headache, nausea and vomiting, can have constitutional symptoms such as fever, may have loss of appetite, photophobia, intracranial pressure will increase, and of course the patient again will have headaches. Patient may have nuchal rigidity and resistance to flexion of the neck. So again, in this case, positive Kernig and Brudzinski sign occur. Hint, hint. Again, the Kernig and Brudzinski sign, we are talking about it in two different disorders, so maybe they are important and we need to know them. Patient even may develop seizures, petechiae, with meningococcal meningitis. To summarize, really, meningococcal meningitis is one of the important types of meningitis, not important, unimportant, but may have high rate of mortality, and again, it's emergency. So your assessment includes at this time the Keringen-Brudzinski sign, which is basically evaluation for nuchal rigidity and petechiae and headache. So if someone presents with headache, nuchal rigidity, Keringen-Brudzinski signs positive, and they have petechiae, so maybe we have meningitis and we need to move forward faster. Brain can tolerate this for some time, but unfortunately, if the treatment isn't initiated fast enough, patient may have devastating consequences or even a demise. Changes in level of consciousness may happen, and also at this point, changes of level of consciousness may be the first initial sign, followed by headache, nuchal rigidity, petechiae. So all this can occur together, but patient may act strangely, even, or level of consciousness may change. Severe headache, again, present. Vaccination is important and recommended for bacterial meningitis, and especially for people living in crowded conditions. How to treat this? Patient may need antibiotics, antipyretics. Depend on the case, the corticosteroids administration may be required. Patient may have the need for pain management, and sometime, very rarely, some surgical intervention, including drainage, may be needed. Encephalitis is an inflammation of brain parenchyma, and often the meninges also involved. So it will involve cerebrum, brainstem, and cerebellum. In the case of encephalitis, hemorrhage, edema, and necrosis may occur in cerebral hemispheres. But when we're talking about encephalitis, this is different from meningitis because of the cerebral function changes. Again, and it's easy to make this connection in cerebral function changes. Encephalitis will have cerebral function changes. However, in meningitis, even we have level of consciousness altered, it may not have the cerebral function changes. So encephalitis most commonly is caused by arthropod-borne viruses and herpes simplex viruses, and the vector is, when it's a viral encephalitis, vector is almost a mosquito. So patient will experience fever, headache, nausea, vomiting, and altered cerebral functioning, altered mental status, motor deficits, and patient even may have weakness and paralysis. Again, please do not confuse encephalitis with meningitis, with level of consciousness, with altered cerebral status. In encephalitis, it may have altered mental status, confusion. In meningitis, it's level of consciousness. Again, in clinical situation, you may have both in both conditions, but in classic book learning situation, in classic presentation of the disease, you may need to distinguish between altered mental status for encephalitis because the cerebral function is affected, and no effect on cerebral function in meningitis. Again, in encephalitis case, patient may need antipyretics, analgesic, may need sedatives even, and corticosteroids. Patient would require ICP monitoring, and even invasive methods may be introduced. Also, antiviral treatments may be needed when the cause is a viral infection. Again, when we're talking about viral infection, it's most likely a West Nile virus infestation or infection. Patient may even present with brain herniation as a complication and death. That's why, again, this is another medical emergency, needs to be treated quite rapidly, and patient would require continuous monitoring as intracranial pressure as well as lab values and ABGs, for instance, CBC and ICP measures. Patient may need extensive interventions to treat this, and also this may present a severe, or not severe, this may present a rather challenging episode for the family and the patient himself while the rapid changes are taking place. And again, I mean by rapid changing the changes in cerebral function and altered mental status.